can break a bone, you can break your teeth, you can burn yourself, you can drown in the bathtub, you can drown swimming. Believe it or not, people who have ongoing incurable epilepsy have a higher risk of sudden death than just the general population. I bring this up because there is a high relationship, there is a high overlap between autism and epilepsy. Various studies have proposed different numbers, and I'll go into some of that shortly. The reason it's relevant, though, is that epilepsy is something that's actively treatable and can change the landscape of what autism means. Being a neuroatypical individual with intractable epilepsy is very different than being a neuroatypical individual without epilepsy. And so this is an area where we do think about treating, we do think about changing seizure frequency, and it does involve medications and other kinds of approaches. So it's become aware to me over the years. A lot of individuals don't realize that there is this overlap between epilepsy and autism. And so the purpose of this workshop is to give you a little bit of information. Remember, as I'm sure you all know, knowledge is power. So the more you know about things, the more you understand what your healthcare professionals are telling you, the more you understand what medications do, and it allows you to be informed and be the healthiest you can be. And then we'll have some time for questions to talk a little bit about epilepsy, seizures, autism, and really provide you with full information if possible. So let's talk a little bit about what we're going to focus on tonight. So I hope at the end of the evening you'll understand what seizures are. I hope you'll understand the definition of epilepsy and the distinction between seizures and epilepsy. They are not necessarily the same thing, and we'll get into that shortly. I'd like you to understand the relationship between epilepsy and autism. The two are closely linked together, often by the same processes that are causing autism. There are a number of genetic causes for epilepsy and autism syndromes, and it gives us the idea that if autism in the greater population has a genetic underpinning, there may be indeed some link to epilepsy in these individuals as well. And then we'll talk a little bit about sort of relationships between the two. So epilepsy and autism, are the two related? They definitely are. An association between autism and epilepsy has long been recognized, and it is now well established. So this is not something that is debated in the medical literature. We acknowledge that individuals who have autism are at higher risk for epilepsy, and individuals with epilepsy, often we see autism in these patients. It really depends on the study you look at, like so many different things. I'm sure many of you are following the COVID literature right now, and one day we hear one thing, the next day we hear something else. It's not quite so bad in epilepsy and autism, but there are ranges that vary between 11 and nearly 40% of individuals with autism who may have epilepsy. That's obviously a pretty big spectrum of individuals. Suffice it to say that the actual number isn't really important. What's important is that the two can occur, and so you as family members or as individuals and your healthcare providers have to be vigilant to the idea that some behaviors in autism may not be part of the neuroatypical spectrum, but rather may reflect epileptic seizures. This is really important because epilepsy is a treatable neurological disease, and we want to try very hard to make sure that individuals are not suffering from seizures and complicating their life by having recurrent electrical discharges in the brain, which are seizures. The frequency of epilepsy, if you look kind of across patients, the frequency of epilepsy is much higher than the prevalence of epilepsy in the general population. So the frequency of epilepsy in autism patients is higher. So if you just took a population of autism individuals, you'd be much more likely to see those who have epilepsy than if you took a similar match, age or sex matched in the general population. So clearly there is this increased incidence. And if you add the comorbidity of intellectual disability, and of course, we all know that autism and intellectual disability, they're similar, they flirt with each other, they have some seam and some connection, they certainly do not define each other. There are many, many individuals who are neuroatypical, who are very, very high intellectual function, and there's many individuals who have fairly profound intellectual disability who have nothing that fits in with any of the diagnostic criteria for autism. However, there are individuals with autism and autism spectrum disorder that do have compromises in cognitive function, have formal cognitive deficits on actual formal testing. And so there is clearly a relationship. If you factor intellectual disability into this mix, indeed, that enhances or augments the risk that there will be epilepsy as well. And indeed, if you screen individuals that have intellectual disability, the likelihood of having autism is also higher than the general population. So some very common genetic autism syndromes I've listed right here. You may have heard of some of these. Some of them may be unfamiliar to you. But Angelman syndrome, DeGeorge syndrome, Fragile X, Rett syndrome, Smith-Magenis syndrome, tuberous sclerosis complex. Among disorders that are, from the general population perspective, very rare, within the autism world, these are actually very common. For example, tuberous sclerosis affects anywhere from 1 in 6 to 10,000 live births. Fragile X syndrome is even higher than that. These genetic disorders are all associated with epilepsy to varying extents. In some cases, it's low levels, and in some cases, like Angelman syndrome and tuberous sclerosis, it's actually quite high, upwards of 70 to 80%. Again, suggesting that individuals who have autism from a genetic cause also have epilepsy that is likely due to that same genetic cause. So it's not two separate problems happening to the brain. It's one common genetic mechanism that's affecting the way the brain cells talk to one another, the way they communicate electrically. The evidence for that you see behaviorally is autism and autism spectrum disorder. The other evidence that you see behaviorally, because seizures are a type of behavior, are epileptic seizures. Now, let's talk a little bit about seizures. So what are seizures? You've all heard the term. Many of us have seen patients or individuals depicted in movie and television who are having a seizure. Commonly, the depiction that we see is an individual having what's called a grand mal or a convulsive seizure. And that's when an individual suddenly loses consciousness. They may cry out, fall to the ground. They usually have shaking or stiffening of all four limbs. There may be excessive salivation, which is sometimes referred to as foaming at the mouth. Individuals may bite their tongue. They may lose control of bowel or bladder. And this behavioral event lasts for anywhere from 2 to 5 minutes and usually stops spontaneously. Seizures, that clinical behavior that I just described to you, result from abnormal electrical discharges of nerve cells in the brain. And on the right here, I hope you can see my cursor. These are 3 individual nerve cells from the brain. And if you will, you can imagine these as little batteries. Each one of them generates an electrical impulse. Each one of them has a positive end and a negative end. And when groups of these cells begin to fire electrically together in an abnormal way, the behavioral manifestation is often a seizure. Now, the picture of a grand mal or a convulsion seizure, while very dramatic and certainly makes the point in television and movies, is not the only type of seizures. Some seizures, as many of you may know from experience or from observation, may be very trivial, very mild. They may include a small head drop or eye blinking. There may be subtle twitching of muscles in the face or the hand. Some of them may be a bit more dramatic, or maybe a portion of the body has stiffening or twitching or jerking. Some seizures have no motor features whatsoever. There's no twitching or movements, but instead the perception is sensory. Patients will feel a limb becoming burning hot or suddenly ice cold, or will have a strange sensation like pins and needles sensation. Some seizures will have a sense of vertigo or profound dizziness. Others will have more psychic kind of symptoms like a sense of out of body or a profound sense of deja vu. So there's a huge range of what the clinical features are of seizures from patient to patient. But from a mechanism perspective, they all result from abnormal and synchronous firing of groups of neurons in the brain. Now, anyone can have a single seizure. Seizures simply result from a sudden abnormal dysfunction in the nervous system that's causing synchronous electrical firing. So what do I mean by that? Well, someone who has a concussion, a head injury, can have a seizure at the scene of a motor vehicle accident. Someone who has had meningitis, where there's an infection in the brain, can have a single seizure. Certainly, we've seen individuals with drug intoxications or alcohol intoxication who, as a consequence of that compound being in the brain, causes a seizure. These single isolated events are just called seizures. They are not called epilepsy. Epilepsy is the condition of spontaneous recurrent seizures. What I mean by that is seizures that have no immediate or clear precipitant. So let me give you an example. If a patient were to come in and have a brain tumor and were to have seizures again and again and again, well, that's not just a seizure, that's epilepsy. That's a person having recurrent spontaneous seizures. A person who's had an old traumatic brain injury who continues to have seizures is epilepsy. So while all seizures are epilepsy, not all epilepsy are seizures. So for our conversation today, yes, it is true that many genetic syndromes are associated with epilepsy, recurrent seizures. But sometimes patients may just have a single spontaneous seizure out of the blue for many, many different reasons. And so that's why we kind of have to be vigilant when an individual has their first seizure. Does this mean that this is part of the whole process of tuberous sclerosis or Fragile X or Angelman, or is this something else? Remember, people with autism can get brain tumors, can have aneurysms, can have strokes, can get meningitis, just like everybody else. What are some of the features that define seizures as opposed to other kinds of behaviors? Well, here's a few things I've listed. Oftentimes, individuals will report something that's known as an aura. An aura is a highly stereotypical, very subjective sensation that an individual experiences as the seizure is starting. So for example, some individuals may perceive a very unpleasant odor or taste. Some patients may feel a funny sensation in their stomach, like a queasy feeling or a nauseous feeling or a frightened kind of a feeling. These auras are highly specific from patient to patient and highly stereotypical over and over. Auras, when we hear them and a patient describes them to us, are important keys to tip us off to think about a diagnosis of seizures. Movements that we see in seizures are often rhythmic and stereotyped, the same thing over and over again. So for example, in a convulsion, a person will have rhythmic and stereotypical shaking of all four limbs that might last 2, 3, or 4 minutes. In contrast, a person who has a fainting spell may pass out and fall to the ground, have 1 or 2 quick little muscle jerks, and then it will stop. Version. What version means is that there is turning of the body. Oftentimes during a seizure, because of where the seizure is coming from, the person's muscles are forced to contract in a certain way, and the person may turn in a certain direction. Almost all seizures are associated with a change in responsiveness. Now, this doesn't mean necessarily loss of consciousness, but it does mean alteration in your consciousness. Most people who are having a seizure feel a little disconnected or a little offbeat or a little off track. They feel as though they might have missed the beat of a conversation. Or I remember a patient telling me he was watching a baseball game and he suddenly didn't understand why the bases were loaded. He had lost some time. He had missed some moments of the game. Similarly, seizures usually interrupt behavior. So if you're having a conversation with someone and you have a seizure, obviously if you're having a grand mal or a convulsion seizure, that's going to be a dramatic event. But some more subtle seizures are simply a person may stop speaking like I just did, or there may be a sensation where the person kind of just stares off into space. Seizures frequently emerge directly during sleep, and we see this on the EEG, the electroencephalogram, or the brainwave test, where we see the person in deeper stages of sleep and then suddenly watch the seizure just emerge right out of the sleep waveforms. Many individuals will have amnesia for their seizures and not even know that they had seizures. I can't tell you how many people in the epilepsy monitoring unit here in the hospital who have had a seizure. We've seen it on the video EEG, we've captured it. I go in and I say, so how are you feeling? Did you have a seizure? No, I don't remember. I can't remember. So it's a common thing. Many individuals will injure themselves with seizures. Obviously, with the more minor types of seizures, injuries are less common, but assuredly with the big seizures like convulsions or grand mal seizures, people can break bones, can get burns, can cut themselves, break their teeth. And so they are very serious events. In fact, grand mal seizures are actually considered medical emergencies. Incontinence, sometimes people lose control of their bladder, sometimes their bowels, sometimes both. The presence of incontinence does not define a seizure, and the absence of incontinence does not rule out a seizure. It really just depends if your bladder is full or not. Post-ictal change. The term post-ictal means after the event. Ictal means ictus, or the event. Afterwards, individuals will often be a little disoriented. They may be confused, lethargic, sleepy, sometimes irritable, sometimes a little aggressive. but there's often a real change in the person's personality compared to what happened maybe at the time of the seizure 3 minutes previously. Oftentimes, finally, patients will experience a characteristic sensation or emotion. They sort of feel like they're going to have a seizure. It might be a sense of dread or anxiety, sometimes excitement. And these are, again, important cues to tip off clinicians to understand what might be a seizure. Now, there's lots of little things that the human body does, some of them listed here, that can look like seizures, but they're just not seizures. And that's where the job of your healthcare professional, usually a neurologist, will help figure out. So things like tics, intermittent muscle twitching of the face or the upper extremities, tremors, hyperventilation. These are things that often are mistaken for seizures and sometimes require more really detailed investigation to figure out. It is true that there's some individuals who hyperventilate with their seizures. It is absolutely true that people can appear tremulous during a seizure. So it's not 100%. It just is something that often delineates itself from seizures. And again, this is something that comes to the attention of your healthcare professional, and it's worthy of asking questions about. This isn't a complete list, but it's a pretty good list of things we often see. So to give you a sense of what's happening, imagine in this schematic here, this is a human brain right here. This red area, you can imagine, is where the seizure is coming from. If we look down here, this is a schematic depicting nerve cells in the brain. So the little triangle with the line sticking up look like little cells. And here you can imagine the cells in red, each one of them start to fire synchronously. That would be the beginning of a seizure. As it begins to spread to more and more areas of the brain, that will spread out and maybe show itself with more and more behaviors. So what might start as twitching of the hand might extend to the arm, the shoulder, and then ultimately extend to the whole body. Because remember, all the neurons in the brain are ultimately connected together, and so electrical impulses can pass very easily across the cortex. All right, so what are some causes of seizures and epilepsy? Well, I've broken this down, and it's by no means a conclusive list. There are many, 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 many things, but just some things that we see according to age groups. So infancy, childhood, childhood, adolescence, adolescence, young adult, middle-aged adult, and older adult. And I put this here because, again, it's really important to realize that autism is a lifespan diagnosis. And so things that can happen in childhood or middle age or even older adults can cause seizures and epilepsy and may be completely distinct from the underlying process causing autism. On the other hand, they may also be completely linked to the underlying process causing autism. And so, for example, things like head trauma in young adults, the 18 to 25 demographic from motorcycle crashes or skateboard accidents. Brain tumors in middle-aged adults are common causes of seizures. Stroke in middle-aged and older adults can be causes of seizures. Neurodegenerative conditions like Alzheimer's diseases are highly associated with epilepsy. Yes, it's absolutely true that an older adult with autism can develop Alzheimer's disease. So when we see patients who have autism, we think about, well, if they ever develop seizures, is it because of the underlying process or is it something different? If a patient with autism comes in with a new onset seizure, no matter what my relationship is with them, even if I've known them for 10 years and they've never had a seizure, I at least think through these possibilities and make sure there's nothing else going on. Maybe it's a visit to the emergency room, maybe it's a visit to my office, a telehealth visit, but the presentation of the new seizure at least needs to be evaluated to make sure that it's not a heralding feature of something completely new and different, distinct from the underlying autism. So epilepsy is the neurologic condition called by spontaneous recurrent seizures. Epilepsy is defined by recurrent seizures. In contrast, it is possible to have one seizure, even a couple of seizures, in the setting of a brain injury, an acute intoxication, meningitis, and never go on to actually develop epilepsy. So it's important to understand this. Epilepsy means you have recurrent seizures, but having a single seizure doesn't mean you're going to go on to develop epilepsy. It's important to look at the incidence. So this is age right here of seizures in the population. So this is young and this is old. The ages are not that important. I just want you to get a sense, this U-shaped curve. There's a high incidence of seizures and epilepsy in the pediatric age group. When you get to the 20s and 30s, this seems to fall off. And as you get to the 4th, 5th, and 6th decade of life, it seems to go up again. Neuroatypical individuals fit right on this curve, just like neurotypical individuals do. So while there is an increased risk of developing epilepsy with autism, it is also true that you can just have seizures at some point in time from other causes that are not linked to the autism. So it can be a little bit complicated to figure out. This is a slide that was from 1999. It's an old slide, and I keep it on purpose because it's really interesting. So this pie chart depicts the frequency of seizures across the demographic in Iceland. Now in Iceland, as you know, very rich and rigorous longitudinal records are kept. They go back to the 1400s. And they were able to put together what have been the known associations between epilepsy and other types of causes. And so you see some things listed here. So brain trauma is one, brain cancer is another, alcohol abuse is one, stroke. But what I love is this big whole group here, 62% unknown. This is question mark. Back in 1999, we just didn't have any idea what the cause was. In the last 2 decades, what we've learned is that a very large number of these cases are actually due to genetic problems that cause seizures. And I say this because many of the same genes here that cause seizures are also autism genes as well. And hence we have this overlap between autism and epilepsy, especially from genetic causes. So this pie chart number is actually diminished very much as we've added in new things like Angelman syndrome, tuberous sclerosis, Fragile X, and other neurogenetic disorders. All right, so we've gone through, I think, a review of seizures, epilepsy. I've given you a little bit to consider in terms of the overlap between autism and epilepsy, kind of the general neurological approach to understanding seizures in both neurotypical and neuroatypical individuals. So let me pause there and give folks an opportunity to maybe ask some questions about any of the material we'll cover, and then we'll go on and we'll dig in a little bit more.
Okay, Dr. Crino, I have one question. Here's the question. Is it unusual for a child with autism to have a first seizure at 18 years old?
So here is my response to that question. That's a really good question. I appreciate you asking that. I expect the unexpected. In medical school, they're always teaching us, they're always questioning us, actually. What % of people have this? What % of people have that? And I never quite understood the importance of it, because if it happens, then it happens. It sort of doesn't matter if it's 10% or if it's 90%. I will tell you that it is entirely possible, sadly, to have a first-time seizure at age 18. In some of the published literature of congenital brain malformations, remember, these are brain malformations that happened during fetal brain development. First onset seizure was in the late 20s. So there appears to be some process by which the brain kind of learns to wire itself so that a synchronous discharge can happen and that a seizure will occur. Remember, brain development doesn't stop in fetal development. Brain development doesn't stop in childhood. It doesn't stop in teenage years. And the most recent data looking at MRI of the brain has suggested that brain development probably stops about age 30. So you've got this period of time from fetal brain development through the pediatric age group, 18, 20, up to 30. The brain is a very dynamic landscape. There's many things changing in terms of the cells, the wiring of the cells, the chemistry between the cells. Think of all the hormonal changes that take place during puberty. Those affect the brain as well. So it's a very dynamic landscape. It is entirely possible that you can have a first-time seizure at the age of 18. Again, I don't want to make anyone frightened, but I will tell you that I've seen people with first-time seizures who have autism at the age of 40. So I'm always prepared for it. I always ask about it in the visit. If there hasn't been anything, I knock wood, and I'm very happy about it. But I have to tell you, I'm always vigilant for it.
Okay, thank you. I have a couple people are asking, I'm going to paraphrase, can you grow out of it?
Yes, you absolutely can. And that is one of the, that's one of the things that I love to take credit for. So I'll start someone on a medication and then suddenly their seizures just kind of go away. And, I clearly say, well, that was my choice of medicine, was the right medicine. And sometimes it's just people growing out of them. I've seen individuals who've had pretty bad epilepsy who get to their 20s and then things just get kind of quiet. Not always. It's very hard to predict who that's going to happen to. I will say that as you get into older ages, such as 40s and 50s, and remember, I come at autism as a lifetime disorder. So my oldest autism patient that I care for right now is 76. Yeah, I often see seizures. They lessen in severity, lessen in frequency, maybe don't go away all the way, but become less of a prominent problem in the 4th, 5th, and 6th decade of life. As I think across my practice, I actually have fewer rather than more individuals who have severe aggressive seizures in their 40s and 50s. So I do hold some optimism that age may just calm the circuits down a little bit.
Okay, I have, I'm going to pronounce this wrong probably, but thank you, Amanda, for the question. So here's the question, is myoclonus common in individuals with autism?
So it is, if it is a type of seizure manifestation that is seen sometimes in, for example, Lennox-Gastaut syndrome, which is a epilepsy phenotype, yes, you can see myoclonus. If you have some types of autism that are associated with myoclonic epilepsy disorders, yes, you can see myoclonus. Independently, I'm not sure that myoclonus by itself is more frequent. Sometimes myoclonus is brought on by medication, sometimes by stress, sometimes it's misidentified as a tic, or rather it's actually a tic misidentified as myoclonus. I'm not aware of a study myself, and I could be wrong, but I'm not aware of a study showing a consistent increase in myoclonus across autism.
Okay, the next question, Cheryl, just so you know, I'm going to provide your question to Dr. Crino after the session. It's more of a personal question, I think. So if that's all right with you, it's pretty long and it might take a little more
Sure.
conversation.
That's no problem. No problem.
Okay, thank you, Cheryl.
Thank you.
And let me just say one second, Tris. Also, at the end, I have my email address at the end. I'm happy to respond to email queries after this as well.
Perfect. Thank you. And thanks for your understanding, Cheryl. Here's another question. How do you separate autism plus epilepsy versus another seizure disorder like LKS or epileptic aphasia? Yeah,
that's a fantastic question. And there's a lot of work going into that. So LKS is Landau-Kleffner syndrome, epileptic aphasia. There's a whole family of disorders that are epileptic aphasias, where the seizures are emanating from parts of the brain where speech and lexicon are developed. And so what we really have is an electrical disruption of the ability to generate speech. As you know, autism, the diagnosis of autism spans more than just speech. And there are many individuals who meet diagnostic criteria for autism who in casual conversation would appear at least articulate. So it's a very distinct sort of mechanism. And it may be an area that is in, and I'm going to talk about this a little bit, sort of one of these borderline overlap areas. Suffice it to say, though, that the language processing challenge that we see in autism is not something that is going to be approachable with anti-epileptic drugs or with some of the therapies that exist for LKS or EA. Conversely, the language processing and aphasia that we see associated with an epileptic discharge in the brain, so a population of neurons in the speech areas that are synchronously firing, that offers a therapeutic opportunity to at least control those discharges and reverse some of the effects on speech. So it's definitely a border zone. It's definitely something that gives us insight maybe into the language problems in autism, but the linguistic problems in autism are not approachable by controlling seizures, where those in EA and LKS, they may well be.
There's a lot of questions here. Let me see. Someone's asking, what are some of the anti-epileptic medications that you recommend for those with ASD? And if you don't want to answer questions that are that broad, it's your call on that.
Yeah, so there is no way to recommend a particular anti-epileptic drug or to disavow any epileptic drug. We have over 20 on the market right now. As I say to patients, all of them are equally good and all of them are equally poison. If you look at the side effects of literally any anti-epileptic drug, you'll be sobered for sure. It's a sobering experience. But anti-epileptic drugs are designed for use across a wide range of epilepsies. Contrary to what I've heard, we are not experimenting. It's not a random pick off the shelf. There are actual indications for certain types of medications for certain types of epilepsies. And so it's very protocolized. We pick drugs in certain ways to target them to patients. Some drugs, for example, cause birth defects, so we try not to use those in women of childbearing age. Some drugs have cosmetic side effects, such as beard or hair growth. Well, in a 35-year-old guy, probably not a big deal, but in a 22-year-old woman, it may have more social impact. Some drugs have toxicity in terms of allergic responses. So we know that among Han Chinese descent individuals, there's an actual genotype of a drug that's associated at very high risk with a very severe skin reaction. So in that regard, we would sort of ask about that person. We can do a genetic test for that spot, and we would not put that person on the medicine. So as an omnibus question, I couldn't really tell you which one is better or worse. There's not one that's better or worse. There are ones that are more toxic versus less toxic. There are drugs that are more sedating versus less sedating. So it really does depend on a situational condition. And remember, none of them are evil or bad drugs. They're just medications, and they have to be deployed in the correct strategy.
Okay, there's a whole lot more questions here. They keep coming. Do you still want to answer questions, or do you want to work on your presentation? Or
let's do a couple more minutes, and then
Okay.
we can start. Maybe why don't we start again at 7:15?
Perfect. Okay. So here's the question. Are there known genetic underlying causes of epilepsy among people with ASD outside of those known neurogenic disorders listed on your slide?
Oh, many. Yeah. Sorry, that was just a list of a couple of kind of marquee ones that you might have heard. They're often in the common literature. The list of genes that can cause epilepsy that may be associated with ASD is long. It's probably 50 plus, actually. And what's more, now that we're doing more genetic testing, and I want to make a comment about genetic testing. Let me finish my thought. As we're doing more genetic testing, we're identifying gene variants in individuals. We're finding new spots that cause autism and epilepsy. We're finding new mutations that are basically informing us as to new disease processes. Many patients, I'll ask them, so have you had genetic testing? And they'll say, yep, oh yeah, we did that 10 years ago. Well, I always say to patients, I want you to pick up your cell phone and I want you to think about what it was 10 years ago versus what it is now. Genetic testing has changed dramatically, and what was done 10 years ago is not even antiquated. It's invalid. And so even if you've had genetic testing, a decade ago, even to be honest with you, even 5 years ago, things have really, really progressed. So genetic testing is one of the things you can always do over and over again, sort of no harm, no foul, as long as you can get it covered by insurance, because it always yields new information. So short answer, yes, there are many, many genes out there that are linked to epilepsy that may have autism-like features, autistic spectrum disorder features.
Okay, here's one. I'm going to paraphrase this one, but this has to do with someone's son developed epilepsy after finishing treatment for leukemia. Then also was diagnosed with autism. Could it be related to chemotherapy, intrathecal?
Intrathecal, yeah. So intrathecal chemotherapy is chemotherapy that is put directly into the cerebrospinal fluid so that the therapy perfuses through the brain and is a more potent effect, as opposed to giving it into the vein where it's a systemic effect. It's absolutely possible that the effect of intrathecal chemotherapy could have had low-level injury in the brain, and as a consequence, the person can develop seizures or epilepsy. If the patient actually had autism going in and leukemia was just a medical kind of unrelated comorbidity, it's hard to know because it would be probably related to the underlying process that's causing the autism. Questions like this are challenging, right? It's very hard to know necessarily kind of what the cause of something was. Suffice it to say that autism in an individual with leukemia requiring intrathecal chemotherapy I'm not actually surprised that seizures have been a consequence of that. And whether it was caused or sort of related to the chemo, I think is going to be very, very difficult to figure out.
Okay, so it's about 7:15, 7:16. Let's get back to your presentation, and then depending on time, we'll go back to questions. And again, if for some reason we're not able to cover your questions, Dr. Crino was kind enough to offer his email at the end of the presentation, and you can reach out to him. So
great. And those, let me tell you, those are great questions, everyone. Spot on. And you'll notice a lot of them, they're not simple questions. Some of them really take some thought. And you know, it's amazing for how many questions we're asked every day. We don't actually have big data sets, and a lot of it is experiential. And so that's why I come at patient care very much as a kind of a team approach, sort of work together on things, because a lot of it just isn't in the textbooks. It's not published out there, and you search the internet, you find all kinds of stuff that's just factually not true. So you do have to be a little bit cautious about some of these things. Okay, so as I said before, common genetic autism syndromes, and we just discussed this a little bit, and there's many more, obviously. All are highly associated with epilepsy. And many of them are also associated with intellectual disability in some way, shape, or form. So how does that factor in? Tough question, right? Tough question. Is it that there is a separate underlying process there? No, it's probably part and parcel of the whole kind of genetic sort of thing here. The synapses aren't working correctly. The cells have not connected correctly. There's not firing correctly. So it's sort of all linked together. We think about the brain and neurology, we think of it as a network. It really is a connectional network that allows parts of the brain to kind of talk to each other. And so the genetic process that we think leads to autism and is associated with spontaneous recurrent firing of the neurons in the brain somehow compromises the ability of the brain to do complicated, rational, abstract, reasoning. And so we sort of have this whole bundle effect. And so, it often comes down to the visit is sort of really looking at these three big buckets here. Autism, epilepsy, and a varying extent intellectual disability. And the challenge for me every day I see patients is that it's, of course, and all of you know this, right? It's not just this, right? It's all this stuff too, right? So in autism, there's other things with autism that are attentional, behavioral, anxiety, subjective feelings of kind of how you get through the day that affect whatever is the underlying process that we see in autism in terms of social connectedness. Similarly, in intellectual disability, it's not just a cognitive issue, it's often sensory and motor and visual and auditory. There's other things that compromise the ability of the brain to perform at its optimal level. In terms of epilepsy, well, remember, most people who have epilepsy are taking the medicines, and the medicines are fairly potent. They affect how the brain works. That affects how your brain activity on the EEG is reflected. Your constant situation of being sort of no seizure, having a seizure, and then post-ictal after the event disrupts the normal integrity of the nervous system. So you've got all of these buckets together. Then you add on this occasionally, right, that you have some kind of medical condition on top of it, whether it's asthma or an allergy or an infection or something else. It completely colors all of the relationships between these very complicated entities. So when I visit with patients, I come at it from kind of the autism, epilepsy, intellectual disability perspective, factor in to what extent they're connected and to what extent other comorbid medical conditions may be augmenting or exacerbating the situation. So, obviously, as all of you know, it's really this, right? And yeah, it's true. Not everybody has all three things. And so we've got some people that have autism and ID. We have some people who have mostly autism and epilepsy. And we've got some people who are predominantly seizures plus intellectual disability with some variable autistic features. And so I'm always trying to factor in with families, kind of what are the active issues? What are the things that we need to address? I will tell you from a therapeutic perspective, we really don't have much for this right now. And we don't really have much for this. I will say that epilepsy, the one optimistic thing here is that we can kind of pull this out of the mix a little bit. And with good therapy, whether it's medical therapy, dietary therapy, we now have devices that are called neuromodulation therapy and epilepsy surgery. We can kind of make that one sometimes go away. A word about epilepsy surgery. Many families come in and they're exceedingly reticent to talk about epilepsy surgery. And I don't know if it's just the frightening prospect of neurosurgery. I'm a father, I have 3 kids. If it was my child who had to go in for brain surgery, yeah, I'd be less than excited about it as well. But I will tell you, when you compare the risk of having ongoing recurrent seizures and the necessity for sometimes 3, 4, 5 medications all at the same time, from a public health perspective, there's actually epidemiological data that says that undergoing epilepsy surgery is actually far safer than constantly having seizures and constantly taking seizure medicines. The other sobering fact here that some of you may have heard at visits, but some of you may have not, is an entity that's called SUDEP, S-U-D-E-P, which is sudden unexplained death in epilepsy patients. This is a disorder where, for whatever reason, a patient has a sudden death. And it's not always linked to a seizure. Sometimes it's not. Sometimes people just have a sudden death. The mechanism for this is not fully worked out. There is some early data to suggest it may be genetic predisposition. It doesn't seem to be suffocating during a seizure. It seems as though it may be more of a primary failure to generate a respiration. Those individuals who have recurrent seizures have a 7-fold increased risk of death compared to the general population. The risk of epilepsy surgery death is less than 1%. So at least be open to epilepsy surgery if your loved one is having lots and lots of recurrent seizures. Again, not everybody's a candidate for epilepsy surgery, but the door, at least to evaluate that possibility, I think is very important, because we really can make epilepsy go away sometimes or greatly mitigate its effect on patient care. So when we talk about epilepsy, sort of threshing it out from autism, what are some of the issues that we have to think through? Well, the first question obviously is the patient actually having seizures. So I gave you a list before of behaviors that we think kind of look like seizures. And yeah, for sure, if someone falls down on the ground and shakes all over and has foaming at the mouth, we typically tend to think it's seizures. But I will tell you, there are some psychiatric disorders in which that happens, and it's not an actual epileptic seizure. It's a behavioral event that's got no change on the EEG and is purely a psychiatric feature. Events of twitching, jerking movements, eye flutter movements, hyperventilation, loss of awareness, all of those things sound like they could be seizures, but it does require a little bit of investigation. So trying to figure out what people are doing is very challenging. Now, for those of you who have experience with neuroatypical individuals, oftentimes we see motor behaviors that are repetitive, they're stereotypical, they happen on one side of the body. And so for all intent and purpose, they could be labeled as potentially seizure. So sometimes a good observational physical exam, I spend a good part of my time in the office just kind of watching people. I have to say the advent of Zoom and virtual medicine has been great, because I can just sort of watch. I get a lot just from observing patients in terms of what they do. But sometimes you can't do it by watching. You actually have to do something that's a little more data driven. Again, if the person is having events, how would you classify those seizures? You know, a convulsion is pretty easy to spot, but something more subtle can be tricky. And so trying to classify what the event is can be very important. This comes back to the question that I addressed earlier, which is, okay, let's say we agree that the person might be having seizures. Is this a chronic problem? Is this spontaneous recurrent seizures that are part of the diagnosis of epilepsy? And if so, can it just be all wrapped up into the whole big package of Angelman syndrome, Fragile X, tuberous sclerosis, some other genetic predisposition that results in autism, variably intellectual disability, and variably epilepsy? Or is this a person who has ASD and has a new brain tumor? Is this a person who has ASD and who has a vascular malformation in the brain? And so these are important questions to figure out because, you know, one of the errors that I see committed by folks who are not specialists is just to assume that everything is always part of the same diagnosis. And it's often not. Neuroatypical individuals can have all the same medical things that neurotypical people can do. So it's important to avoid that bias and not just see the world in a single spectacle. A critical question is, if you do think it is a chronic problem and it is epilepsy, to realize sort of how are the seizures interfering with normal life. So what do I mean by that? Well, I can think of a few patients who have 5 seizures a day. And it's really disrupting their life. They can't drive, they can't hold a job, they can't do childcare, they're afraid they're gonna get hurt. It's really compromised their social life. And it really is causing a complete upheaval in anything that they ever saw as a narrative for their life. In contrast, I can think of a few individuals who have maybe 2 seizures a year. And yeah, they're annoying, and yeah, they wish they weren't happening, and yeah, they've gotten hurt a couple times, but they sort of just live with them, and they just kind of say, yeah, that's part of who I am, and no, I don't really want surgery, and I don't want to take more medicine, and I'm just kind of content where I am. I think as a caregiver, it's really important to ask this question because not everybody has to be seizure-free. I often say to patients, look, I'd rather have you have a couple of seizures every now and again and maintain your beautiful personality and your love of music or art or whatever it is than make you completely seizure-free but so sedated on medicines that you just have lost any interest in life. So it's really a vital question to try to figure out. From a more practical perspective, you say, okay, is the person having seizures? Well, how do we get at that? You know, obviously, you're going to ask the patient. In some individuals where a verbal history is not possible, we're going to depend very heavily on witnesses who've actually watched the event. It's very important as a physician to be sensitive that you know, if this is epilepsy, this is going to be a heavy diagnosis to lay on some people, and you're going to have to really be supportive and empathic and really help them kind of get through this. We have an objective test, which is known as an electroencephalogram. Many of you, or your family or others that you know may have had this test. It's a painless test, takes about an hour in the outpatient area, and it's very, very informative about looking at individuals' brain waves and helping us render a diagnosis of epilepsy. Sometimes we can do a prolonged EEG as an outpatient, so 24 or 48 hours, which obviously gives us much more data. And not infrequently, we have to admit patients to the hospital, and we have a dedicated unit known as an epilepsy monitoring unit, or an EMU, where you were admitted and you might stay 3, 5, 7 days. You're on a video camera with EEG wires hooked up, and we basically just record continuous EEG with video for the whole duration to really, really look at what's happening in your brain waves when you're awake, when you're asleep, while you're reading the newspaper, watching TV, and if you have any of the clinical events that you've described. The American Academy of Neurology has an actual practice parameter for how we evaluate seizures in all patients, neurotypical or neuroatypical, it doesn't matter. It includes a good history, a physical and neurological exam. I know many of you may have participated in a neurological exam and wondered what the heck it is that we're doing with all this stuff and our hands and this stuff and reflexes. But believe it or not, it's incredible information. And as a neurologist with a silly little hammer, I can get more information sometimes than a $5,000 MRI. So it's really important to have that process. As I mentioned, electroencephalography, whether ambulatory, whether an outpatient, or whether inpatient, it can be very important. Many of you have had brain imaging studies, whether a CT, otherwise known as a CAT scan, or a computed tomography study, or magnetic resonance imaging, MRI. This takes pictures of the brain and show us levels of detail that are unimaginable. When I first started as a neurology resident, we did not have MRI at the University of Pennsylvania. It was a new technology. When I finished residency, we had it. We had a magnet that was 0.5 Tesla strength. Today's magnets are 3.5 to 7. So it's really a whole new world. And then finally, if we think seizures are due to infection in the brain, then we do have to do something known as a lumbar puncture or a spinal tap. Not everyone with seizures has to have a spinal tap. Not everyone with epilepsy has to have a spinal tap, but if the suspicion is high that you have an infection in the brain, if you have meningitis or encephalitis, then a lumbar puncture is indicated. These practice parameters, pardon me, are used by every neurologist in the United States across all 50 states. These are the standard protocols that we use to evaluate patients. Now, what does the EEG tell us? Why do we do that? Well, there's certain waveforms, I'll show you pictures of them, that are called epileptiform activity. Epileptiform activity are waveforms on the EEG that are highly predictive, 95%, that an individual has epilepsy. Now, it's true, when we bring people into the hospital for an hour, it's unusual that we're going to actually capture a clinical event. It's too short a time. But ambulatory EEG at home for 24 or 48 hours, or bringing someone into the hospital for prolonged EEG monitoring, often does capture an event. And quite honestly, if we see an event and it shows up with spikes or sharp waves, epileptiform activity on the EEG, we have made a diagnosis of epilepsy. Conversely, if a person has an event and there is no change in the EEG whatsoever, well, the person's clearly having something, but one thing we can kind of check off the list is that this isn't epilepsy. These aren't seizures, and it's probably something behavioral like a tic or a tremor or something else. The final point is that if we see abnormalities in a focal area of the brain, so let's say your son or daughter is 35 and they started having events of altered consciousness, we get an EEG and it shows epileptiform abnormality in the right frontal lobe. Well, that would be concerning that there could be some new disease process in the right frontal lobe, such as a tumor or a stroke or a vascular malformation that needs a workup. Again, that's completely separate from the person's underlying autism. This is just kind of general medical neurological things that happen to human beings. So this is also very important. And if we see something abnormal in the EEG, as part of these practice parameters, we get some kind of a neuroimaging study. Many of you have seen this. This is what an EEG looks like. I shamelessly took this off the internet. So here's a patient. You can see them lying comfortably. Their eyes are closed. Here are the wires that are going to carry the brain activity back to the machine. Each one of these are just pasted onto the head with a very sticky kind of yucky smelling stuff that allows the electrode to stick to the head. If you're going to stay for a long period of time, we actually put an actual glue on the electrode to glue it to your scalp, and we'll wrap your head up with a bandage so that you can't pull off the electrodes. So what does the EEG look like? Well, there are certain normal rhythms. They're all Greek letters, alpha, beta, theta, delta. There's, in some places, there's gamma as well. Alpha rhythm is the normal brain activity of the awake, resting brain. This is sort of a kind of a marker of a healthy brain if we see alpha rhythm. You can see here, there's an awake brain. It's got some beta activity. Here's an awake, resting brain with alpha activity. Nice background activity. Here's a little bit different. You can see it's slower rhythm. This is sleeping. And then a person who's deeply asleep, like kind of snoring asleep, might have this real deep delta kind of activity. All of these reflect normal waveforms, normal transitions in the human brain. Individuals with autism frequently have completely normal EEGs. We see nothing that is epileptiform, nothing that is abnormal. We see an alpha rhythm, we see sleep, we see all the normal stuff. This is what an EEG looks like from an actual human patient, and I just want to show you right here that here's an event right here. This is what a seizure looks like on the EEG. This is pretty subtle, but you can see that in contrast to here, which is kind of flat, this part begins to pick up and get faster and faster and faster. So it does require some skill to read these. Neurologists or epileptologists are the ones trained to read these EEGs. Now, I mentioned epileptiform activity. Some of you may have seen this on reports for your loved ones. Epileptiform activity refers to things called spikes or sharp waves. This is an example of a spike right here. Sometimes you'll see something called a spike and wave discharge. This is it right here, spike and wave, spike and wave, spike and wave. This is diagnostic of epilepsy. If you have this discharge right here, this means you have epilepsy. So it's a very, very useful technology for us. If we see this, whether on a 1-hour study or on a 5-day study, this really makes the diagnosis for us. Now, if an individual is having a particular behavior, we look to see if these spike waves are happening during the behavior. Because if someone's doing an event where their hand is going like this, and we see spike wave at the same time, that tells us that this event is an epileptic seizure, and that allows us to embark on a treatment algorithm for that individual. Finally, a little bit about brain imaging. Brain MRI still is the best technology for visualizing the brain. You can see just about anything there now. Really, it's an unbelievable technology. There is a contrast material some of you may have heard of, which is called gadolinium. It's given by vein intravenously. This allows us to see certain structures in the brain, like tumors and other kinds of abnormalities with a little more clarity than the scan without it. I remember at an autism meeting a number of years ago, there was a kind of an argument that kind of grew up out of the audience. Two kind of camps as to whether or not people felt like they should, MRI should be part of the workup of autism, or should it not be part of the workup for autism. And it's interesting that debate has really gone back and forth and shifted. Suffice it to say that an MRI is certainly going to give you information, even if it's normal. Number two, the presence of a normal MRI in an individual with autism and seizures almost always means that the person has an underlying genetic process. Number three, having a normal MRI, whether you're neurotypical or neuroatypical, is kind of a nice thing because it tells you don't have an aneurysm or a stroke or a brain tumor. And a lot of individuals, they just feel better knowing that their MRI looks pretty normal. The CAT scan is much lower resolution than an MRI. We really use it to see if someone has bleeding inside the brain. So if your loved one were to have a seizure and they go to the emergency department, almost everybody gets passed through the CAT scanner, really just to make sure there's no kind of catastrophic event that's happened. But it's really not useful to divine any kind of structural process that might account for what's going on. So we still go back to MRI. And then there's other scans, PET scan and SPECT scans, that are part of an epilepsy surgery workup that I won't go into here. So I'm going to stop right there, and it's about 7:40, and that gives us some time to have some conversation and questions. I've included here my email address at the University of Maryland. Please feel free, if you have questions, to send me an email. Just identify yourself as a participant in the webinar, so that I, can put the context of where you're coming from. And it might take me a little time, but I will get back to you. And for those of you who are in search of a caregiver for an adult child with autism, epilepsy, or intellectual disability, we'd love to see you at the University of Maryland. I do want to make a public service announcement, and that is the individuals that we see over the age of 21, they're adults. And I frequently, I have parents of 37-year-olds and even older parents of 45-year-olds will say, oh, this poor kid's been through so much. You're an adult now. And the reason it's important to sort of draw that line in the sand is that it allows us to think more effectively and appropriately in terms of medical care for individuals, because, some of the comorbidities that we see in adults, we just don't see them in children, right? So emphysema, COPD, is not really a disease that we see in children, but we sure do see it in adults. Stroke is a disease that we really do see in the adult population, not so much in kids. So I think it's important to realize that this really is a transition. Once you get past 18, 21 to your mid-20s, you're an adult now, and you're seeing an adult doctor. The other point that's important to realize is that pediatric care is very different than adult care. I think all of us have fond memories of our pediatricians, and I know many of you have had fabulous pediatric neurological, pediatric psychiatric care. Pediatric care, as a general rule, is very family-centered. It's really focused on sort of this holistic view of the family. Historically in American medicine, adult medicine really is patient-centered. It's focusing on the adult. What we try to do at Maryland is sort of a combination of the two. Our job is to take care of an adult who has ASD, epilepsy, intellectual disability, and work as a team with family members to really secure the best outcome possible. It's important to realize that at the age of 25, 35, 45, we may not have any therapies for autism. We may not have any therapies for intellectual disability. But there are certain things we can do for behavioral modification. Sometimes it's medication, sometimes it's CBT, sometimes it's other things. Epilepsy is absolutely approachable as a neurologic disease. And so one of my missions is to make sure that, I've done my best to really minimize seizures in my adult patients, because that's something that no one should have to battle, neuroatypical or not. So that's kind of my approach. Epilepsy adds tremendous morbidity, tremendous risk factors, and as I mentioned, even a risk of sudden death to all individuals. So I really want to see. I want to do my best to kind of make seizures go away. So again, I'll thank you for your attention, and I'm happy to take whatever questions folks have.
Okay, thank you, Dr. Crino. That was wonderful. I'm just going to scan through here a little bit and see if we have some different things. Someone's asking about medical protocols. For example, what do you think about like dietary changes? You sort of talked about prescription meds already. Someone had asked about CBD.
Sure, so all those things. So dietary protocol, I constantly get people say, we need to cut back on the amount of sugar. And I know every time he has French fries, he has seizures, or, behavior goes off the wall every time we have, McDonald's. The truth of the matter is there's absolutely zero data to support any of that. There's just no data. And families often look at me and they give me sort of a screwy eye and say like, well, this guy doesn't know anything. It's not my opinion. I'm just telling you what the literature tells us. Believe me, if I found out that chicken nuggets were the cure for autism, I'd be giving them out left and right. It just isn't there. Now, let me back off that for a second. If you consistently observe that, for example, drinking high sugar soda or high sugar sports drinks or candy or high carbohydrate cookies and treats and things like that is associated with worse behavior, aggression, agitation, irritability, yeah, I'm all in. I believe that too. And that applies to neurotypical and neuroatypical individuals. A good diet applies to all, and those foods are all poor dietary choices. So for that, yes, I will agree with you completely. As far as their role in causing seizures, there's just nothing that shows that. Caffeine, really nothing. Alcohol, the data on this is that if you have epilepsy, the consumption of alcohol should be moderate, less than 2 glasses of alcohol, which is a glass of wine, a beer, or a shot of liquor per setting. And certainly you should never drink to intoxication. Alcohol is a neuroactive drug, just the way, just like Lexapro is and Celexa is and Tegretol is. So adding alcohol to that mix makes things more complicated. The same thing obviously goes for illicit drugs, including marijuana. Cannabis is an incredibly complicated biomaterial that has over 400 chemicals in it. CBD, cannabidiol, is one extracted compound from cannabis that seems to have a potent effect on seizures in a limited repertoire of patients: tuberous sclerosis, Dravet syndrome, and Lennox-Gastaut syndrome. It has not been shown to be an effective therapy for all types of epilepsies. The effect in autism has not been shown in a double-blind crossover placebo-controlled trial, so I think all results at this point are anecdotal. Given the fact that most CBD that you get that's not from a pharmaceutical company has some contaminants of THC and other CBD-like compounds in it, I think the buyer beware. I think you be careful. There's been no real studies to show that any of those things are particularly toxic or harmful to you. So, you know, I don't prescribe them. I don't see the benefit of them, but I think there may be a spot for them in the future. Right now, CBD, which is marketed as Epidiolex, is an anti-seizure medicine that's really indicated for only the 3 epilepsies that I mentioned before.
Thank you. Let's see. Here's one from someone. Is it unusual for a teen who has a history of focal seizures to all of a sudden start to have grand mal seizures?
Sadly, no, it's not. I'm sorry. I wish I could tell you no. Seizures can be very mercurial. They can be very shifty. And just like somebody asked me before, can seizures go away with age? They can also worsen with age. They can change shape. I've had I can think of one person off the top of my head whose seizures were right hand twitching and right face twitching, and they were that way for years. And then out of the blue, she had a grand mal seizure, and now her seizure picture is kind of both types of seizures. So yes, unfortunately, they can morph, they can change. You know, in theory, every seizure you have is kind of a bad seizure because it sort of teaches the nervous system. It teaches the neurons how to have seizures. It's one of the amazing things, the molecular processes that cause seizures, believe it or not, they are virtually identical to the processes that are responsible for learning and memory. So it's almost like you're building a circuit in the brain that kind of knows how to have a seizure.
Okay, there's another question. It's more personal. Okay, well, I'll ask this one. It's her son has grand mal seizures, sometimes that last more than 7 minutes. Can you talk about meds like Valium that can be administered to stop a seizure in process?
Yes. I'm sorry you're going through that. Seizures lasting more than 5, 6, 7 minutes are very scary. The data is that 80% of patients who have seizures will stop seizing in less than 5 minutes, 80%. So if you're seizing more than 5, 6, 7 minutes, you're in a small percentage of individuals with epilepsy. There is a condition that is known as status epilepticus. This is a condition in where you have ongoing, unremitting seizure. They just don't stop. The definition of that now is actually 5 minutes or longer. So 7, 8 minutes is really status epilepticus. And what's the damage of that? Well, the damage is that during a seizure, you're generally not generating respiration. So you're not breathing. So your brain is not really seeing the amount of oxygen that it needs. Secondly, during seizures, there's a number of metabolic changes in terms of the pH of your blood. There's muscle breakdown. There's decreased filtration of your blood by your kidneys, changes in fluid flows in your lungs. So a prolonged seizure is actually something to, to really try to get on top of. There is a whole set of medications, which began with, many of you may be familiar with a medicine known as Diastat. Diastat was just rectal Valium or diazepam. It works often very well. The rectal mucosa inside is actually very much like the oral mucosa, so medications can go across that very easily. The obvious challenge is, if you have a 5-year-old, it's pretty easy to, take down trousers. If you have a 42-year-old and you're out at the mall, boy, that's really complicated. So that drug is certainly useful pharmacologically, but practically is a little more challenging. The newer drugs that have come out, there is a new medicine, which is Nasolam. I'm not endorsing it. I'm just telling you the name of the medicine, which is a nasal form of midazolam or Versed, which is the compound we often use in general anesthetic procedures, which works very well to stop seizures. There's a new nasal Valium that's out, and I'm sorry, I'm having a senior moment. I can't think of the name. If anyone knows, please write it in the chat, which is a nasal form of Valium, which seems to work pretty well. I've had some success taking lorazepam or Ativan and simply putting it under people's tongue or sliding it between their cheek and gum. So all of those strategies work. And honestly, for the person who asked that question, if you want to send me an email about that, please feel free. But I hope that you're seeing an epileptologist about that, because that's a real challenge for sure.
Okay. Is there a coordination of genetic testing between hospitals? For example, the Spark test, if you're familiar with it.
Boy, I wish there was. No, there isn't. Genetic testing has been the Wild West. Any of you been through genetic testing? It's been all over the place. And so here's the challenge with genetic testing. When we say genetic testing, what do we mean? Well, there's many different types of genetic tests, right? There's something that's as simple as a karyotype, which is basically looking to see that you have the normal complement of chromosomes that the human body has, which is a cheap, inexpensive, easily accessible test that anyone can have. There is array-based testing, right, where we look for big chunks of DNA that are missing across the genome. There's panel testing, where we actually look for variants in particular genes, and they often line these up as genes that cause epilepsy, genes that cause autism, genes that cause intellectual disability. And then there's actual sequencing of the exome, which is all of the genes that code for proteins, and then something called whole genome sequencing, which you basically take blood from a patient. You can do it with saliva, but usually blood, and you sequence just every nucleic acid that's there, every DNA that's there, you sequence. Now, the advantages are the panels will tell you, do I have a mutation in this gene? And so if someone is thinking about, do I have a mutation in the gene for Rett syndrome or CDKL5 or Fragile X, we can test for that exact mutation and tell you, yes or no, you have a mutation. But if your panel comes back normal, usually it's only about 150 to 200 genes. That leaves an additional, 10,000 genes that we haven't studied yet. In contrast, if you sequence the whole genome, invariably what happens is that you get back these changes in gene sequence all over the place. They have a name affectionately that's called a VUS, or a variant of unknown significance. These, we just don't know what they mean, right? Every human being has subtle variations in their genetic code. If we took everybody here on the call today and ran our whole genome, nobody would be identical. There's all kinds of little changes. Well, the problem is when you see that change, does it mean the individual has a gene mutation that's causing autism and epilepsy, or is it just a change in their DNA sequence? So it can be very, very challenging. No one yet has put together a clinically useful sort of platform that travels across medical facilities that allows us to do gene testing in the same way. There are certain companies, I won't mention them, but I'm sure many of you are aware, that are out there that do gene testing. The challenge for all of you, of course, is that there is highly variable insurance coverage. Some of you may have seen bills of $1,000, $2,000, $3,000. A couple of them now have it with the copays only out of pocket of maybe $100. There's no place you can go to for whole genome sequencing unless it's a research protocol that's not going to cost you several thousands of dollars. So it really does still remain the Wild West. It's maybe a little less wild than it was a decade ago, but still there's some significant challenges.
Okay, I'm going to sort of combine a couple of the next questions because they seem to be all about some kind of process or procedure to help. For example, this one question might be a little different, is how do you know if your child should get epilepsy surgery? And then let me just ask the other ones in one lump. They want to talk about, do you believe in seizure dogs? What about vagus nerve stimulation? And what about external, using the ear for VNS?
A couple things about epilepsy surgery. Epilepsy surgery has to be decided by an epileptologist. So this is not something you can do with a community neurologist at a community hospital. You typically have to go to a tertiary care center where there is someone who is a bona fide epileptologist. The consideration for epilepsy surgery starts with the question, are you a candidate for epilepsy surgery? Not, are we going to do it on you? It's, are you even a candidate for it? The starting variable that we use now at most centers is from a published paper in the New England Journal of Medicine about a little more than a decade ago. And it says that if you have more than one seizure per month and you have already failed 3 medications, either alone or in combination, then you probably have something called intractable epilepsy. You will likely not respond to subsequent medications, and you are at least a candidate for consideration for epilepsy surgery. Once you've crossed that threshold, then your epileptologist will say, okay, we're going to bring you into the epilepsy monitoring unit. We're going to taper off your medications. We're going to induce or allow your seizures to happen. And then we are going to record your seizures while you're on video. We'll see what you do during the seizure, and then we'll correlate that with the brain activity. That first step allows you to do something that's called lateralization. Are your seizures coming from the left or coming from the right? For some people, that may be enough to proceed to epilepsy surgery. Sadly, for many individuals, it's not. And you have to proceed to something called a phase 2 evaluation. A phase 2 evaluation is when electrodes are actually neurosurgically implanted into the brain in the area that we think the seizures are coming from, but we just can't figure it out from the electrodes on the scalp. Same thing, you'll be in the hospital for a week to 2 weeks with those electrodes. We'll stop your medications. We'll see if we can find the spot where your seizures are coming from. Whether from a phase 1 or a phase 2, based on the EEG data, the MRI data, and a number of other tests that we do, we will decide to offer you epilepsy surgery. But remember, epilepsy surgery is not a brain tumor. It's not a life-threatening situation in the sense that this is happening right now. It's elective surgery. You can choose to have epilepsy surgery or choose not to have epilepsy surgery. So some of it is patient agency for sure. But that's the general process for how we do this. The vagus nerve stimulator is a neuromodulation device that is not brain surgery. Same thing with any other kind of neuromodulation that is not entering the brain. So there's an electrical device put right here under the chest wall. A wire goes up to a nerve in the neck, and literally like a heart pacemaker, the device fires impulses that travel up this nerve in the neck, and it goes all the way back up into the brain, and it modulates the network in the brain. Sadly, the efficacy of the vagus nerve stimulation has not been that fantastic. Most people see only a very modest benefit. Very few people become seizure-free. And so I think its popularity will continue to wane. Many epilepsy centers have really stopped doing vagus nerve stimulation. It is a nice thing to do if you don't want to go right to brain surgery, because it can be taken out and it's not actually brain surgery. Now, I think what you're talking about with the ear is responsive neurostimulation, which is basically a little computer is implanted in the skull and an electrode is placed inside the brain. That's a little more high tech. It's FDA approved, but it is sort of sci-fi a little bit. In that situation, the little computer that's implanted in the skull learns what your seizures look like from the brain, and using an artificial intelligence algorithm actually learns when to give a counter stimulation to try to abort the seizures. Responsive neurostimulation, we do it here at Maryland, just like we do regular epilepsy surgery, is a growing technique. For some people, it has been an amazing help, especially those people who have failed epilepsy surgery or who are not easy candidates for epilepsy surgery. And so for those individuals, we have had some real success with responsive neurostimulation. So there's lots of potential modalities for treating epilepsy that don't involve medications. I will tell you that the only cure to date for epilepsy is epilepsy surgery, where we take out a part of the brain that's causing seizures. The vast majority of people, 70%, if they're well localized, will go on to be seizure-free. The risk of that surgery is probably less than 5%. So if you can have epilepsy surgery, you have your best opportunity for cure.
Perfect. So we are out of time, actually. It's 7:58, and I want to thank Dr. Crino for his time and his tremendous amount of knowledge and patience with all of our questions. And if we didn't get to your question or comment, please, as Dr. Crino said, feel free to email him, and his email's still up on the screen. And I want to thank everyone for joining us. We have recorded this session. We will probably tomorrow post it so people can access it. And again, thank you so much, Dr. Crino.
Thank you, everyone, for your great questions. It was a really fun dialogue. I hope I was able to answer some things for you. Please feel free to shoot me an email. I will get back to you. It might take me a little time, but I will. And just the last point, I know you're all, every day it's a challenge. As I said, I've been doing this for almost 3 decades, and I've heard lots and lots and lots of stories over the years of the things that you deal with every day. I'm always impressed at how much people do for each other and families do for each other. So, just hang in there. There's always hope. We're going to figure something out one of these days. I promise you. It's been slow coming, but my real support and congratulations to all of you.